I'm a little bit more caffeinated after that short break. I mean, one of the benefits I think in that us being together is that we take some time, obviously, to talk amongst each other with coffee and things. So we encourage lots of that conferencing, to use the proper term. But we're moving now to panel 5, which is about repair and a resilient Canada. And in brackets, this panel was toward a national repair strategy. In many ways, it asks us to look at the right to repair from a slightly different angle than what how we normally kind of frame the right to repair and its rationale. And so there are these traditional kind of maybe framings, rationales, policy responses, all of which we've heard discussion about over the past day and a half, almost. And you know, the sustainability lens obviously is prominent and familiar to us. Consumer protection, of course, is another strong kind of rationale and policy response in terms of reforms for the right to repair. There's the community building aspect, the human aspect of bringing people together and sharing knowledge. So maybe a less productivist sort of idea, but still very much a rationale and important policy focus from the grassroots in terms of the values in repair. And then lastly, this kind of innovation or market competition, the idea of there being more active competition in repair markets being a benefit for us all in a kind of market economy. And so all these rationales remain absolutely central to our thinking about the right to repair. But this panel adds another layer, or I hope it will, is repair is a question of national resilience, sovereignty, and preparedness. And this framing feels especially important in Canada's current geopolitical moment. So we're living through, obviously, a period where trade relationships are being reevaluated. Supply chains feel less settled than they once were. And the assumptions of ever-deepening economic integration, especially with the United States, are no longer as stable as they once seemed. And Prime Minister Mark Carney recently captured this shift by saying that many of Canada's former strengths, based on its close ties to the United States, have become our weaknesses. Now, and I hesitate to kind of overemphasize that point of view, given that we have so many friends in the room from the United States. And I just want to acknowledge that within the right to repair community, we are all one family. However, there is this kind of, from a federal perspective in Canada, this concern, this deepening concern about where we are headed as a country and how we will survive these new trends. And so whenever one thinks of that formulation, it reflects a broader national conversation about dependency, self-reliance, and the need to build more capacity within Canada. And that's where repair becomes much more than a consumer issue or those other framings. If we're worried about fragile supply chains and trade disruptions, procurement bottlenecks, and the availability of critical technologies, then repair capacity becomes a form of infrastructure. Repair becomes like an input for infrastructure. And so traditionally we've spoken about like the rights holders of the right to repair as being kind of one of two groups, right? It's individuals as consumers, like you or I, or it's businesses, independent repair shops, refurbishers, and so on. But resilience adds a framing of a new stakeholder in this conversation, which is public institutions. And this panel will be focusing a lot on particularly health institutions, hospitals, health authorities, and even those within our national defense infrastructure. So we've seen like this kind of thinking emerge also in the US in the context of military procurement in the past year or so. And there's been a much more visible debate about a military right to repair in the US in particular. And similar conversations are now taking shape in Canada. And they may not always use the language of the right to repair, but they're clearly about repair, maintenance, procurement, operational continuity, and public capacity. So we see this in Canada as well in healthcare. There's been a long running conversation that Kevin Taylor I'm sure will touch upon within our biomedical engineering community about the importance of medical device repair and servicing for our public health system. We also see it in defense and public procurement, and so we'll hear a little bit about that perspective as well within the Canadian Armed Forces. So the question for this panel is, what would it mean to bring repair into this type of conversation directly, into more of our public institution and our national resilience thinking? What would it mean to treat repair access as a part of public procurement, as a part of health system resilience, as part of infrastructure planning? And perhaps most importantly, what would a national repair strategy look like if it took public institutions seriously? Not just as regulators, but as owners themselves, as types of stakeholders and of rights holders of the right to repair. So we have an excellent panel to explore those questions. We have Kevin Taylor, who's the co-chair of the Right to Repair Committee with the Canadian Medical and Biological Engineering Society. We have P.O. Mike Sidoroff, a senior biomedical engineering technologist, team leader with the Canadian Armed Forces. And Alan Spurway is a clinical engineer focused on medical device cybersecurity with the Nova Scotia Health Authority. So with a strong focus on medical devices in particular, we'll kind of use that as a case study, to think about repair as not only a matter of individual ownership, but as Canada's ability to remain resilient as we head into the future. So I'll turn it over to Kevin as our first speaker. So thanks so much, everyone.
Hello, everybody, and I really appreciate being given the opportunity to come and present to Can Repair for the second time. So this is exciting. I'm the Territorial Manager of Biomedical Engineering for the Northwest Territories, and we also, through an intergovernmental agreement, support 2/3 of Nunavut Territory through in-house biomed support. But I'm also the co-chair of the Canadian Medical and Biological Engineering Society, or CMBS is a short form that you'll hear me say through the rest of the presentation. And I realize that even the people here who are heavy proponents of right to repair may be going, yes, but. So we get that a lot in healthcare. And I'll go through some of the narrative that our position on it as CMBS, as the actual biomedical engineering experts in Canada, our position on it. I'll go through some of the narrative that's happening out there. And I'll go through some simple examples to try to help you see how important it is and how important it is for the resilience of our healthcare system in Canada as things are happening. So about 5 years, CMBS, I mentioned, it represents the biomedical engineering professionals in Canada. We're not a lobby group. We're actually working biomedical engineers. So all this work is being done on the corner of engineers and technologists across Canada's desk. And that puts us at a bit of a disadvantage because we're not lobbyists, we're not marketers. We can't produce beautiful, glossy material. I see Ellen Gardner here. She is a professional writer. She's helped us numerous times to smooth out our language. When we originally started our position statement on this about 5 years ago, it was like 2 pages long. So her fingerprints are on this. So basically what we believe as the professional engineers, as the biomedical engineering professionals in Canada, is you're hearing, oh, it's safety, but it's actually the opposite. By blocking the right to repair, the manufacturers are knowingly, in an attempt to monetize service, are knowingly causing safety and delays in care and timeliness of care, aside from the increase in cost, which is actually also causing a delay in care when you think about it, right? Because every extra dollar we spend on service or capital equipment, because the lifespan's been shortened, causes impacts on the frontline services that we're providing. But the last sentence is also very important. It's very easy as a champion for right to repair in healthcare in Canada to get us against them. But it's actually, there are a lot of good companies out there. The majority are still compliant. It's an increasing trend, and it's about working together. Like, we have to work together. COVID demonstrated that. If we're talking about resilience, we were able to work closely with manufacturers to ensure the stability of our healthcare system. Right after COVID, they said you can no longer touch our equipment, but during it, they were very flexible. So what's the false narrative that's happening? Now, a lot of these are very similar to what you've heard other people in other industries talk about. But the first one that really surprises me, that it's still coming up, and I actually had a director of regulatory affairs in the US for a major medical company say it to me. And then when I wrote her and said, she said her legal counsel has advised them that it's against regulations for us to provide you service training. Only in-house, not third party. It was really weird. Only in-house. It's against regulations, right? So I wrote her formally and said, can you provide us with that? I know the lawyers here would love to have seen that analysis. And of course, she never did. And their sales reps will constantly spout this. And for the procurement specialists who are just there, if there's not a biomed backing them up, build a wall, we have to eliminate that requirement, or we'll have to negotiate that out because it's against regulations. We can't do that, right? But it's a completely false statement. There are no regulations in the US, Canada, or Europe that block provision of service materials. The other thing that often is brought up is, of course, safety. Safety. They said it for cars. They say it for, I imagine they tried to say it, John Deere probably tried to say it for tractors. But safety is an issue. And that puts us as the actual experts in an almost impossible position when it's been presented to decision makers. Because now you have to prove a negative, which for anybody who did a lot of calculus means you need an infinite number. But we got pretty close to that. So the FDA in 2018 did an analysis of 2 million events and actually said there's no risk. And in fact, the sustainability of the US healthcare system requires third-party service in their state. So 2 million isn't an infinite, but that's pretty serious. So when we do presentations with and working groups with industry, we say, guys, don't get in fights unless you have a report and analysis of more than 2 million events. Don't say safety at the table. You're just going to cause a fight. The other thing is we say they're starting to say, because of the FDA report, they're starting to say more and more we want qualified individuals. So the major lobby group in the US a couple of years ago in their annual report actually bragged about blocking the US military from having right to repair of their medical equipment in war zones, and said it's because they want to ensure that only qualified people work with them. Well, it's not a straw dog argument, it's a self-fulfilling argument, because they're the ones who provide that material. So of course you're not going to be qualified. And interestingly enough, the FDA did a guideline on remanufacturing versus repair. And in it, they said the availability of quality, safe, effective, the lack of adequate service structure creates challenges for the availability of quality, safe, and effective devices. And consistent with promoting and protecting the public health, the FDA encourages OEMs as an industry best practice to provide, so they're self-monitoring, I guess, to provide servicing instructions to facilitate routine maintenance and repair. It's only guidelines, so there's no teeth to it. But the FDA themselves are saying this is for safety, guys. So the other thing that is coming up is they're starting to stop saying those, or when you push them on those and you knock those arguments aside, the last group says you just knock those arguments aside because there's no basis to them. We're concerned about the third-party service companies and the qualifications people. We need regulations. So that's the latest thing that they want is we need regulations. We can't really deal with this until we have regulations, which is a 10-year process, right? But we do in Canada. We have, Canada has the mandatory medical device reporting requirements. So if a device injures a patient in a Canadian health facility, you must by law report that to Health Canada. So if a third-party entity did something that caused the device to injure a patient, we'd have to report it. Never seen it in my entire 30-year career. Never seen it in the 10 years I've sat on committees that reviewed those reports. But we'd have to do that. So we have regulations. What's the issue? Also, we have accreditation. So every 3 years, our hospitals go through accreditation. In the leadership momentum, so leadership has to demonstrate that they have a maintenance program in place. So professional engineers and technologists have SOPs, policies in place to ensure the quality of the service that's occurring, whether we do it or somebody else does it, right? So these are the arguments that are presented, and they're done really well. Glossy material. Ooh. How much time? 5, okay. False, so those are the arguments that are provided. They're kind of false narratives, but that's you heard this. So I'm going to give you some practical examples on how they directly impact your care here in Canada. So the biggest one is delay in care. So we in the Northwest, if I went down the street to the IWK, grab 1 or 2 of the most junior staff out of there, they could give you examples. Ellen Gardner was teasing me. She hasn't heard very much of it. If I started giving you stories, we would be here forever, right? But delay in care. So we had a laparoscopic insufflator. It blows your insides up so they can do the keyhole surgery with CO2. It's just a CO2 regulator. A little piece of plastic covers a temperature probe broke off the front. We knew exactly the part because this company actually gave us the service manual, but they wouldn't sell us the part. We had to wait a week for a loaner unit to come in. We had 1/3 of our laparoscopic capabilities down in the entire territory because of that. So I kicked a bit of the stink, had the company's senior person in Canada on the phone. They were willing to give me $100,000 loaner forever system rather than sell me a probably even with delivery $20 part. And the maintenance cost me $5,000 when I set it out. Well, when all was said and done. There's profit in them not. So it's about money. Blocking independent investigation. This gets kind of conspiracy-ish, but, and I'm going to flip the narrative on this one. There are good companies out there that recognize the benefit of working with in-house. So a dialysis company in Western Canada had a machine that caught fire. The engineer, in-house engineer, because they are training, because they have the manuals and stuff, did the analysis and found out that a minor component in a very specific situation in the power supply would have too much current flowing through it and it would catch fire and burn and then cause a fire. So they got actually free engineering support from that. But this company also recognizes that they amplify their service and essentially have a free engineering team and service team by training people. And in the case of the Northwest Territories, the last set of dialysis equipment we bought, the company insisted we were factory trained before they would sell it to us so that it would be maintained correct. So we can maintain dialysis equipment, but a suction pump can't be maintained because of safety. A little bit crazy. Other thing, and this is a big one, and this has a direct impact on care because it's a direct impact on cost, is they shorten device lifespan. So a company was infusion pump. It's the only infusion pump company blocks right to repair for safety reasons. They have a policy that if you send their device, because you have to send it to them for repair, if it's older than 7 years from date of manufacture, not from date of acquisition, which could be up to 3 years from date of manufacture, they automatically destroy it. Destroy it. I'm not kidding. Destroy it. So they force you to buy a new one, even though that model is still sold and it has exactly the same part still. So it's about money. And then the other one, again, money, unfortunately, is it's a blank check for cost increases. We had a service contract, full service contract, single device, very complex device. So we made the business decision to do a full service contract because we wouldn't see enough failures to make it our techs worth with cost training and maintaining it. The company changed, changed things, 50% increase in the service contract cost. Not CPI, not 5%, 50%. And when we pushed back on them, it wasn't the only argument, but I like, okay, you just made a business case for third party, or we go to the Canadian Medical Equipment Protection Plan. Thank you. They dropped the price on it. Oddly enough, they dropped it to cheaper than we paid the previous year. But they were going to increase it 50% because they could. So why do we need resilience? I've already mentioned the win-win aspect of it. Like, actually, by working together, they amplify their service capabilities. And why is that important now too? You can't hire qualified biomed techs. The older techs have all retired, and those were the older guys that were willing to travel all over the place at any time, any place. So companies are no longer able to meet their commitments even on their own for service contracts. And these are good companies, the ones that are trying hard. So it actually adds resilience by allowing it. And good companies are starting to realize it and they're working with us. Okay. But then also things are changing. So there's the market supply chain issues, restrictions and trade that are happening, but also, we evacuated the Northwest Territories and the capital city during COVID. You couldn't get anybody in. So that's one of my senior techs went to the National Emergency Strategic Stockpile. So these are real life things that are happening. So that's just kind of a snippet. There'll be more questions. Happy to talk to people afterwards. So we're not just the yes, but it's actually important for safety. Thank you.
Morning. My name is Finance Mike Sidoroff. I'm a BE Tech by trade in the Canadian Armed Forces. I've been in the forces for about 23 years, 15 years as a BE Tech. The intention of my presentation today is to talk about how the CAF addresses the challenges associated with right to repair in the absence of legislation. Some of the challenges we're unable to overcome, and they're just part of doing business in the CAF. So I'll overview procurement, the actual right to repair, and overcoming some challenges. So our first step is to ensure that the right to repair is built into our contract with technical service training. And we'll build in options for additional training at later dates. If we get new techs in the military, they'll need that same training as well. And we'll use specific verbiage. So some of these lines include that the technical service training must be provided to D&D techs, BE techs, with the knowledge necessary to maintain, insert any device name, the same capability to the same capability as the original equipment manufacturer's field service engineers. They must also provide licenses to us. So the contractor grants perpetual non-revocable licenses to use, reproduce, translate the training reference manuals, materials, and documentation. Service keys, the contractor must grant each participant of the technical service training all service keys necessary to perform maintenance for the device lifespan. And service manuals, we will request current service manuals, and subsequent updates must be provided for the duration of lifespan of the device. And providers must give us the proprietary tools, software, and test jigs required in order to service and maintain the equipment, as well as access to parts. They can't just give us the training and not sell us the parts as well. And that may look like a set price plan over a few years, 1 to 5 years potentially. And some more complex devices that don't deploy outside of Canada will typically reach service agreements with possible technical training at a later date. So the reason that the CAF requires the right to repair is there's limited access to service. Civilian techs cannot, will not, or are unable or not allowed to travel to where we have the equipment, either located internationally. Domestically, this is typically not an issue. CAF medical equipment is also often used outside of the clinical environments as well. So our commitment to NATO in Europe right now has equipment in highly mobile facilities. Previous missions with less capable opponents allowed us to have more semi-permanent facilities, but they were in more arid, very dusty areas. So environmental factors would often void our warranty, meaning we had no choice but to repair our own equipment. One issue we do have is remote access to medical devices. So military IT infrastructure and security prohibits remote access to our more complex devices, such as CT scanners or X-ray devices. So we must work with the companies with heavily constrained restrictions that prevent quick fix situations, unfortunately. And one of the only ways we can mitigate this is frequent technical exposure to these devices to enhance our proficiency, which is not always possible due to the wide scope of equipment and responsibilities that we deal with in the CAF. Okay, so overcoming challenges. Ensuring that technical training is included in the procurement contract is the easiest way for us to overcome that problem. It ensures us the legal right without legislation, but I would argue that the cost associated with the contract reflects those rights. And it does not include or cover low dollar purchases that don't meet that threshold for contractual procurement. Government contracts can also be an issue because it's always thought that we had to go with the lowest compliant bidder. But when a contract is constructed properly, you can allow for weighted criteria and higher scores to meet optional requirements and bonus points for hitting specific criteria. Though not an ideal solution, one other option is volume purchasing or stockpiling required devices and sending them back to Canada for repair after the fact. But that's a very costly method to do a business. One key component we have to consider when contracting for medical procurement is the end of useful or service life. Clauses require bidders bidding with certain devices to have an expected supportive life for at least 10 more years. That prevents companies from dumping old stock or near end of life stock on the Canadian Armed Forces. And unique repairs, one problem we have is unique repairs can't always be eliminated. There's one specific device, it's a high fidelity patient monitor that does defibrillation. And if the main board on that goes, it must go back to the LVM in order to be calibrated properly. There's nothing we can do about that. We wouldn't be capable of procuring the equipment required to do that kind of service. And it wouldn't be done in a field environment. Collaboration is my last point. So national collaboration amongst the VE tech shops across Canada is our biggest strength. So we draw on each other's experience and expertise. And so it's kind of like a provincial network or the provincial government would have for their healthcare service. CAF has also worked with other federal agencies in the past. Kevin mentioned the Public Health Agency of Canada and the National Emergency Stockpile during COVID. We sent 6 techs at a time to go and assist them with receiving massive equipment. We've also worked with Canadian Coast Guard and continue to do so. Previously, we've worked with Corrections Canada as well. And even locally, I knew 8 or 10 years ago, and apparently a couple of years ago as well, there were central sterilization issues with the hospitals downtown. And when that occurred 8 or 10 years ago, the Canadian Armed Forces allowed the local health agencies to use our reprocessing systems in-house at the Halifax Medical Clinic. That's my presentation.
Good morning, everybody. So I'm Alan Spurway. I am a clinical engineer with Nova Scotia Health. I also am a member of the Right to Repair committee with CMBES, as well as the founder and chair of the CMBES Clinical Engineering IT Working Group, which is national working group looking at how biomedical engineering and clinical engineering can integrate with IT services and to support the medical devices. So I'm just going to talk a little bit about medical device software and the right to repair responses around that. So software and medical devices, anything that does any sort of computation has software in it, of course. And the data that we're computing with our medical devices is often, obviously, health information. And health information is immutable. You can't change it. So unlike other banking and other things, it is a high priority for people to get because you can't change it at the end of the day. It is your fingerprint. It is who you are. So altering that data is nearly impossible. I mean, we all want to as we hopefully improve our health. But it is really hard to do. So it is a target for bad actors and things. So we do have to be very conscious and careful, careful with our IT connected devices. And everything is getting more and more interconnected as we go. So it's becoming more and more of a complicated mess that we exist within. So medical device regulations, this is Health Canada regulations, specifically look at the performance of software, and it shall be validated when a medical device is certified for use within Canada. It cannot be sold within Canada unless it's receiving either the organization that sells it, the vendor, they have to have a establishment license, or the device itself for Class 2 and above. The device itself is actually certified and has a license to be used. So these are some of the examples of devices with software. We've got, this is an intravenous pump here, and this is a point of care ultrasound, runs off the phone. So any medical device with this integrated software with these sort of things can be either customized software running the firmware like the pump here, or it can be used in commodity hardware, typically, HP, Dell, Windows-based computers, iPads, Zebra phones running Android OS, those sort of things. So you can either have kind of a mix of the two, and that comes with unique challenges for both around the right to repair side. The pumps, for example, or things in that kind of vein. I'm not picking on this pump company. They work well. I'm just saying that, these sort of class devices where it's an integrated firmware, well, that's very closed down. It's very independent. It may not be running something Linux-based. It may not be running anything like that. It might be, and I just don't know it because it's not showing a nice, pretty screen. But what it's running, it can be more complicated, which sometimes is nice because it's harder to hack that way, but it's also harder to support if you're not doing it. The other side of that the things running a standardized OS, Android, Apple, iOS, Windows, Mac, whatever it happens to be, those operating systems, when the devices are supplied by manufacturers, are a component of the medical device. That operating system is the software that they also have to support, and it's mandated that they are. As I mentioned, it's mandated they are. This is Health Canada and the FDA. They are required as part of the, these are guidance from both companies or both organizations, but it's required that the ongoing monitoring, cybersecurity reporting and mitigation is required as part of your healthcare license to keep operating the device. So it's not an optional thing for them. And it's one of the things that we kind of can use as a bit of a cudgel is like, you need to be providing patches. You need to be providing this. Right repair is not an option for you. We need to be able to fix these. We need to be able to support them and integrate them and things like that. So modifications. I bring this up just because, as Kevin mentioned, we are allowed to fix things. We can do things. We own the devices, and as healthcare organizations, we are allowed to make modifications to healthcare devices. We don't want to because that takes it out of a validated state, and we are then responsible for anything that happens afterwards. The liability comes on us, and if something were to happen, and we report it to Health Canada and all of the other things, the question becomes, why were you operating outside of a validated state? And then so, you know, we can potentially be on the hook. But that being said, things like adding antivirus onto a system could be considered a modification. Applying a patch that's not validated is technically a modification of the system. And if you look here, class 3 or 4 medical devices, if you modify the operating system, if you were the manufacturer and modify the operating system, that actually requires a resubmission to Health Canada before that modification can be done. And we, on the other end, could just do it. So we just have to kind of go in with our eyes open. But as I said, like, it is supported by Health Canada. It's also supported by C244 and 294, reiterated there, breaking the software locks, you know, doesn't prohibit us. There was no carve out for medical devices in either of those laws. However, as I said, we do transfer the burden of risk. So going in with our eyes open and doing risk management procedures to make sure that when we are modifying devices, when we're making changes, when we're doing any of these supports, when we're connecting things online, we are doing it with our eyes open. We make sure that we protect them. We decide not to, we sign contracts, whatever we're having to do with these devices, we just have to do it in a risk controlled manner. Oh, and right at the bottom there, it said, like, once you make a modification, selling it, donating it, which is cost as a sale, even if there's no money to take hands, that becomes more complicated because now we're the manufacturer and we have to do a whole bunch of other things and blah, blah, blah. So it just becomes more complicated once you start doing that as well. Just kind of a minor kind of offshoot of SIMD, which is software in a medical device, is SAMD, which is software as a medical device. This is where the underlying actual physical components or operating system is not part of the medical device. A good example of one of these is period trackers on your phone. Your phone is not a medical device, but the software on it is a medical device. It can link with hardware, but it doesn't always. This is really, really nice in a kind of right to repair kind of aspect because if your device breaks, you can get a new one and just load that software back on. Yes, the software itself is controlled by the medical device manufacturer, in this case, the software company. And hopefully they're updating and things, and that could be a different aspect, but the actual physical components are kind of divorced from the software. So yeah, medical device, they are a unique and regulated aspect in a regulated environment. So it is a different kind of understanding. It's not just a consumer grade device where once you buy it, you should be able to kind of do whatever you want. So there is some nuances to it because you know, healthcare is all about balancing risk, and modifying that is part of it. So it is very unique. And as said, Health Canada, as well as C244294 support modification of devices and right repair. And then, as I said, let's perform risk assessments before we do anything because lives can depend on it. I mean, we all talk about medical devices, and there can be, if you do things wrong, pretty big issues. My references, that's me done. Thank you all for these incredible talks, and I just want to start with some kind of a higher level, like big picture question.
We've heard a lot yesterday and today about repair barriers in the private sector context. But just looking for like an open question for all three of you to just opine on, like, how is integrating repair into public sector operations, and I use that term broadly, different from, advocating for rights in terms of consumer protection or other traditional forms of regulation. Like, what is it about public sector kind of repair rights that presents unique opportunities, challenges more so, that, how does the sort of the fight for repairability play out differently?
I'll kick off a partial answer to that. So government procurement is a long process. It takes a while to get the specs in, to get them validated, and a lot of times now, most provinces now have sort of procurement shared service entities. So they're vanilla bean procurement officers. So they don't understand the unique nature of health technology. So a vendor can say it's against regulations, and they'll go, oh, okay. So you have to take the time to educate, and sometimes it's every single time, the procurement officer, so that they understand that these are actual requirements and that they are necessary, just like you would say, I need Health Canada licensing or CSA. So to back that up, you will often need to have a policy yourself, or you won't have any legs to stand on.
On the federal side, we have medical clinical engineers that actually help us build our contracts. They'll help us build our statement of work or statement of requirements, and that'll alleviate the issue that you're referring to with contract specialists. They will review our contracts, but it will eliminate the potential for them to be talked out of including something into a contract. We are able to push the issue, and they'll keep what we're actually looking for for the device to be able to do as part of the contract requirement.
Another little bit is when you're dealing with a healthcare authority, at least in Canada, it's publicly funded, and so while not legislative, you're signing contracts with what is essentially a government body. So there's that, and there's in Nova Scotia, for example, there is 2 health authorities. There's the IWK and Nova Scotia Health. There is very limited. We represent 1 million people here, and so there's limited kind of customers, and we all talk to one another. So hearing where things go, there's that kind of limiting aspect of when we make a choice. We make a choice for a while, and then we can let it lock in. So there's a little bit more kind of we can use. We can not play competitors against the other, but they want to work kind of with us to make those sales.
So this is full disclosure. I'm leading a research project into medical device repair in Canada. So I've asked some folks in your field some of these questions already, but and maybe this is more of an issue for Alan and Kevin than Mike, because it sounds like in Canadian Armed Forces, the loop has been closed a little bit in terms of connecting the people in charge of procurement with the people who are experiencing the downstream impacts of barriers to repairability. Like, there's actually some communication there, but my understanding, and correct me if I'm wrong, is that in the public health context, health authorities, hospitals, outside of the Canadian Armed Forces, that there is a kind of a communication issue or an organizational issue where the folks in charge of procuring the devices aren't the ones who really are familiar with the downstream barriers to repair. And there's a kind of, the head doesn't talk to the arm type of situation. Is that a correct assessment?
When a purchase process is started, clinical engineering is often involved, whether or not we're fully involved as we should be. But we should be sitting at the table as with clinical to make sure that the correct devices are purchased, and then we can advocate for right to repair, advocate for services, for those sort of things. I know in the past, one of the first things cut out of some contracts to save money was, oh, well, we don't need that support training. It's like, how are you expecting us to support this going on? It's the conversation within the organization, and it's people refresh and things. So it's an always ongoing conversation. But you just get your foot in the door, see the table, and then continue that sort of thing.
Yeah. In the Northwest Territories, we actually have the same advantage as the health technology planning finding team at the Department of Health and Social Services are all biomedical engineers and professionals, and they define the specs and create the specs, and then work with our procurement shared services people. But even then, we took our time to help them understand, and they're now the biggest champions for us on our clauses, whereas when they first saw them, they were kind of like, you can't do that, you can't do that. So we had an advantage that we were able to go through that because we have a territorial, we're the first jurisdiction in Canada to have actually a territorial policy on right to repair for health technology. And but we needed that policy too, otherwise the procurement people, the tail would be wagging the dog very quickly. Well, you can't do that. And we said, well, it's actually policy. Oh, okay. And that's a magic word when you're dealing in a bureaucracy. Right. So.
I know that in conversations about policy development in this space, there's been assertions by medical device manufacturers and their representatives that, opening up greater repairability for medical devices is particularly vulnerable to certain acute public harms through, tinkering. What if a device fails? We can't just let anyone with a wrench work on it. And I'm just curious if you have any thoughts for all of you, I guess, on how to neutralize some of those concerns. Because when we're talking about medical device repair, those safety, public safety, and then cybersecurity questions are somehow more effective, even as empty as they are, in terms of persuading policymakers that if we're going to have right to repair policy, maybe we stop short of medical devices. We've seen almost this in the United States as well. It's kind of almost a no-go zone in a lot of cases. And so I guess, how do we prevent that same thing from happening here?
When a device is repaired, it isn't just put back into service and given to clinicians to use. It's put through its readers. It's checked against the manufacturer's specifications to ensure it's operating as it's supposed to. So it's I won't say it's the equivalent of taking a car for a test drive after a repair, but it's essentially the medical version of that. So there is things in place. The actual servicing of the device post-repair confirms its functionality.
I mean, there's incoming inspections when you buy a device. A brand new device will get checked to make sure it works as advertised, it wasn't damaged and chippered, things like that. We don't even trust a brand new, fresh off the line device. We're not going to necessarily trust a repair device until it's confirmed as well.
Actually, Dad, one point to that before. When we receive a batch of devices, if a certain number of them aren't functioning properly, we reject the entire order.
And in Canada, we have an added advantage that deflates that argument quite a bit is our educational institutions are accredited. So the engineers come from accredited engineering programs, the technologists come from accredited college technology programs. The people who are doing the service and hired by the government or that we hire as, say, third party to verify their qualifications are qualified people to work on the equipment. And then the healthcare facility is an extremely secure facility. So Bubba with a wrench isn't walking in and trying to fix a metal. It's not happening, right? They're qualified people. So the argument kind of falls apart. When I was talking to a lobbyist executive one time, they got kind of wrapped up on that idea, and then they, again, knocked these arguments aside easily. They pulled up a slide that they had sent a Walmart blood pressure machine that was supposed to talk to an iPhone and a company that did iPhone repair said, well, we'll have a go at it. So there's somebody not qualified, but that's a consumer grade medical device. It's not a hospital grade medical piece of equipment, right? So they had this one little example that they should show. It wasn't a practical or reasonable example.
And so on the same theme as this question of competence in repair, I know that when repairing a lot of medical devices, there's this relationship between training and what are called service keys. And I don't think it's widely known. So I wonder if you folks could maybe just explain a little bit about this relationship between training, service key, and how that plays a unique role in medical device repair in ways that we don't see in other types of products. That in order to get the key, you have to do the training and so on.
So there's different levels of medical devices. So if you brought all the biomeds in Canada into a room, none of them would disagree that for a ventilator or an anesthesia machine or a dialysis machine, you have to be factory trained. But a vital sign monitor, we hire qualified biomed techs. If they have the service manuals, they can do the work. And depending on the complexity of the device, we might say, yeah, well, we'll pay for the training as well so that you can you know. So there is that element to it, but then so some of the devices, yes, you absolutely have to have the training, but what's happening now, and it just happened last year, because one of my colleagues in Toronto, they sent their engineers for a diagnostic imaging piece of equipment training. They got them back, they got the service manuals, but didn't get the service software, the service tool. And this major vendor said, they first actually, the person said it's against regulations, and then there was a huge hue and cry, and they backed off on that. But it turns out they gave it to their US counterparts, but the policy for the Canadian element was we don't give it, you have to sign a contract in order to get the service software. So they are starting to play games with that as well.
And then there's some devices out there, things like big surgical robots and stuff that are only sold with service contracts, but you go in with your eyes open. And so this is a closed down thing. And it's kind of essentially, I don't necessarily own that. I am paying for it to be in my facility for us to use, but it's not mine. And so if the contract is, like, if the company wants to be like not right to repair and provide all the service and all things like that, and be involved in every case, because oftentimes those are also, like, they're involved with actually setting it up and making sure it's ready to go. I mean, that's fine, as long as we are knowing that going in and we can make that informed decision. So, I don't want to touch this.
Just a quick one more thing popped into my head is you also have to do the full life cycle cost analysis. So companies are also starting to increase the cost of those service keys. So you, in your purchasing tender or your RFP, you make it clear that for 1.5 times the lifespan of the device, and this is the defined lifespan, if we have to pay for a service key, that's cost is shown up front, so your competitiveness is going to go down if you charge us an unreasonable cost, and we want to know what that cost is for the lifespan of the device. You define that. And then when you have that, the company can't come, although we'll try, like that example I gave, and just increase it by 50% the next year.
So my perception is when we talk about, like, we'll say conventional right to repair discussions around like consumer products and devices or industrial and commercial ones, it's somewhat easier for us to measure impacts in terms of cost, delay. My understanding is in the healthcare context, trying to connect some of these barriers to patient outcomes or service delivery is a challenge. And my perception is that part of that is that getting the information that we would need to connect those dots is not so easy. But in your view, and this I guess is for all three of you, how do we close that loop so that it would be easier to kind of explain the impacts of barriers to repair in terms of like the real human impacts, the outcomes?
I'm excited here. So I would have said, yeah, I didn't hear you very much, Kevin. Canadian Medical and Biological Engineering Society encourages its members that if they come across a situation where there was a delay in care or even a safety issue, of course it's a safety issue, but if there's a delay in care that impacted patient care due to a blockage on the right to repair, they should submit, and it's called a voluntary submission to Health Canada, and then Health Canada will review that. And one of the ways to deal with this is we have to start getting this data. Again, we are in-house biometrics. We're so busy. The officer was saying that he couldn't come yesterday because he's so busy. We're so busy that doing a voluntary thing often drops down to priority, but we're strongly encouraging our members to start doing this so that the risk is actually documented, and then we can start dealing with it properly.
One thing is, it's a hard thing to quantify or measure because there's already patient wait times out there. And if a patient wait time is already 3 months and it goes to 3.5 or 4 months, and then maybe they catch up a little bit, you can't tell if that's due to volume of patients in or equipment service downtime. So that would be a hard data point to track.
You'd almost have to not do it for a period of time and hurt people, and then start doing it and go, oh, okay, I can kind of improve it. So
the data also may be there, but maybe not well documented, presented. Like we manage a lot of fleet equipment, so we know what come next RFP time or whatever it is, what was our current, like why are we replacing it? Well, the service time went up. Because we're tracking that, we're looking at it, we're looking into these things. Is that well documented enough that we can kind of provide it to researchers? Probably not, because as Kevin said, we're very busy. So it's like, yeah, it broke and we moved on, why it broke and why it took so long to repair, and those that may not be documented well, but there is the functionality that we can do. We all have computerized equipment management platforms and databases that track our equipment and track our work time and all those other things. Like, it's there, it's just maybe not in a well-to-do kind of easily accessible fashion.
Right. So some work to do.
Got some researchers that want to clean up some data? Because
Send them your way. This question, I guess, a little bit more from Mike, and I guess it also speaks to kind of impacts. And you know, my understanding is that healthcare is one of many priorities of the Canadian Armed Forces, right? And so, can you speak at all about how barriers to repair impact overall operational readiness of the Canadian Armed Forces?
Absolutely. So there's two parts to this. There's the operational aspect in that when deployed and going on missions, the availability of health care and the devices that are required to assist soldiers that have been injured, if that's not available, that actually changes the mission that the Canadian Armed Forces is able to achieve or attempt to achieve. Domestically, if we don't have the equipment ready to go, it prevents our sailors from getting on the ships to go to the fleet and sail around the world. It prevents our soldiers from being able to deploy into harm's way. So, the last thing we want to do is put people into harm's way without a way of helping them should they become injured due to that.
And I guess overall, like, so there's impacts there in terms of operational readiness. There's impacts in terms of patient outcomes, delays, so on. How do we, this is kind of an open, collaborative question for you all to think about. Like, how do we channel that into a question of the theme of this panel of national resilience? How do we? I guess this is more of a political or advocacy question. How do we communicate that as something that is connected to Canada's current priorities and concerns?
Well, things like the position statement and online stuff, because I haven't worked in the Department of Health as a project manager and analyst. You do a lot of searching, so as more information is available in a format that is consistent and easy to understand, you can start dealing with some of that to get the message in to counter the opposing message, I guess, that was incorrect. Yeah, so communication, I think, is one of the major ones.
there's other aspects to, we interface, maybe not directly, but the organizations interface with the government directly, with the departments of health and wellness, or whatever the naming may be in your various provinces. And so there is interaction there with the lawmakers who would be doing these things, with the budgets, because this is an impact to budgets. So that there is a path through organizationally to reach to those kind of places, to put in the policies that I know, Kevin, because you have that close working relationship with the government, that you were able to put policies in place that we're all trying to copy or homework off of.
Next question, I guess, is, and I think Mike and Kevin both alluded to this, like the difficulty of medical device repair, in particular in rural and remote, or just difficult to reach situations, maybe non-civilian settings. Can you comment at all about like those dynamics of repair and maybe barriers to overcoming it? And I understand in the Canadian Armed Forces context, there's only so many barriers you can overcome, because those are some of the conditions you're given, but maybe, Kevin, also you can comment on the kind of the northern kind of view of this issue.
So it's substantially more amplified, because even when we have full service contracts, we had a major vendor, I guess I've been off for a year and a half ago, didn't, on a $70,000 contract, full service, 2 visits per year, did not set foot in the territory at all. Didn't do their job. And we didn't ignore them. We were calling them nonstop, and they still didn't come. And then when we called them on it, they said, well, we'll give you a 20% discount on next year's contract. So this is happening because they can't get the bodies. So from a resilience perspective, and from a challenge for us, because like you got to understand, to go to one of our more northern communities, they could get stuck there for 3 or 4 days. A major vendor on anesthesia equipment, after they had that, after their colleagues in Nunavut, just said, we're not giving you a contract anymore. best effort and time and material. And their time and material rate is like $500 an hour. So Nunavut came to us and we said, well, we're factory trained on it. We'll help you out and we can collaborate on coverage and everything else so it makes the trip cost effective. But that's because there's an alternative. If there wasn't an alternative,
You'd have to wait.
and you pay, and the vendor still wouldn't do it, and you don't have a choice of what we're doing with the contract. Okay. Right? So the fact that you can get trained, you can say, okay, this is not cost effective. I just gave you $70,000 in getting, I can send somebody for training for 40, say, even if they charge me a crazy $20,000 tuition rate. Actually, I can send them for less than, and then I can have a person trained and I don't have to pay people. Or I can hire a third-party company who has the business model and has people trained.
Yeah.
But if they don't allow it, we're done. And we won't get service, and then service will fail.
With respect to the CAF, when we're in remote areas, I mean, we've got a station up in Alert where we have medical equipment and a small medical team that keep everybody up there healthy and safe. So we'll send techs up there in advance or annually to service the equipment that's up there. But we'll have to pre-position our equipment, and throughout the year we just can't go up and see them on a ad hoc or short notice timeline. So it's got to be a planned trip. So in that case there may be service exchanges. But when we're talking about being over in Europe, fighting any transgressions that may be occurring over there, it really comes down to the availability of the testing equipment, the spare parts, having ample spare parts for common and uncommon corrective maintenance, and a surplus of batteries on site, which includes procuring them from European sources. But then there's the unknown that comes with warfare. You don't know what's going to happen in any one time, especially when you have a more capable adversary. And on top of that, there's several big devices that may go over that require techs to have specific training. So we have to have more techs trained on that device than there may need to be, because we have to cycle people through those environments. We can't just send the same person and have them stay there for 3 or 4 years. We will send people for 3 to 6 months on rotations. That's how we would approach it.
I'd also make the point that this might be a rising tide floats all boats kind of thing, because while Halifax, Nova Scotia wouldn't be classed as remote, although we have some more rural areas, the service and tech people are Quebec or Ontario. So not for everything. There are some people based in Halifax and things, but there are a lot of people who are regional for the Brunswick, Nova Scotia PEI area, or they're based in Ontario. And so it's flying them in or shipping the equipment up, and that's 4 days to ship it up, and then 4 days to ship it back, plus whatever service is needed in the middle. I was talking to a vendor once about service training, and he just made an offhand comment that people out east and people out west require the training, or are asking for the training much more than people in kind of the central Ontario region, because the repair depot is down the road. So it is, great, it's broken, and then it's there the next day and getting fixed, and back the day after that. So while not remote, we still have the same sort of complications just because of the population dynamics of Canada.
I'd like to just add to flip the narrative back from us against them comment, because I gave you an example of a failure. Manufacturers who will work with us will come and say, we have to do this critical recall. Usually it's software related or something like that. We don't know how to get to these communities. We're like, listen, we're going through them anyway. Let's work together. We know how to get there. We know how to move the devices to the north. If you do it, you're going to lose equipment and everything else. So we'll actually work with them if they'll work with us, and the system just is like infinitely better.
Absolutely, like we're on site every day. They're not. We can easily apply stuff to whatever device it is and keep it up and running and keep it active because we're there.
Now, I know, Kevin, that you have kind of some first-hand experience with shaping procurement policy in the Northwest Territories. This next question is about how do we improve public procurement standards for medical devices across the board? Like, is there some opportunity for harmonization so that across different health authorities and provinces we're following the same approach? Is that too optimistic of a goal? Are there institutional barriers to doing it? Just thoughts on that.
There is there are a few barriers in place. Like, we're actually government of the Northwest Territories employees, so we're bound by the Financial Management Act. So the way we build clauses are bound by that. Other things are separate authorities that are like a step away from it. So they actually have more flexibility. From the Canadian Medical and Biological Engineering Society perspective, that's position statement is on our website, and our plan is to create a member portal which would have, here is all the NWT's SOPs, policies, templates. Alberta and BC are very close to implementing clauses. So we're trying to harmonize it. I never met Petty Officer enough until today, but he was talking about some of the clauses they had, and they're very similar to what we have. But like, we have our scars. It took us 3 years to refine this. Service manuals of the same level as the original equipment manufacturer. Service training of the same level. So we're harmonizing language like that. We did it by accident the same way. We're from scars the same.
A synchronicity. Okay, well, maybe before we open up to questions from everyone, just maybe each of you come up with sort of one practical change that governments or public institutions, like Canadian Armed Forces in Mike's case, could make to kind of improve repair access and strengthen resilience. If you were asked, if you have one wish that could come true, what would it be?
I'll jump first. One thing we recently started looking at, we purchased a device and kind of find out after the fact how robust the actual maintenance is on that device. So we started looking at including what is the annual maintenance and repairs, what do they look like as part of the service life of that device, and factoring that into that weighted criteria I mentioned for our contract. And so a device that requires exponentially more work may not get as many points as a device that's a little easier to work on. It doesn't need to be hooked up to a computer to reset an annual counter or something to that effect. On a device that's maybe just a patient warmer that you put the blanket over the hot air blanket over the patient. There's no need for it really to connect to a computer when every other previous model, it's a thermometer or a temperature probe and electrical safety. It's additional software that doesn't really feel like it needs to be there. So we'll consider the actual biomedical aspect of it when setting up a contract.
Right. So some uniformity there in terms of like when that's actually necessary.
Yeah, and just to get an idea, just to get an idea of how in depth that commitment's going to be on an annual basis, and is that juice worth the squeeze?
Right.
My opinion is to work within the leadership of the different organizations, health organizations, hospital organizations, to develop a policy on right to repair, just as a first step. Because for us, that was huge, because what we were running into and what our procurement people were running into is the company would just say, that's not our policy is we can't provide it. Well, now we can say, well, actually our policy is the opposite, so now we have to discuss this. And that is hugely effective. And then everything else falls from there. And to the defense of the procurement people, if it's the whim of Kevin Taylor, they're going to be very skeptical. But if there's an actual written, concise, referenced policy in place, they'll follow it.
I think that one of the points that we could look at and work on, at least nationally and everything else, is around the Health Canada regulations and the guidance that they publish. They publish, pre-market, specifically on cybersecurity, pre-market cybersecurity guidance, which talks about you have to patch it post-market things, and there are requirements that they have for post-market surveillance and post-market support. Well, there is a leverage that they can put in place to be like, okay, great, this has to be provided at a right down in an economical fashion, or you can't, withhold it. They have that power to look at like the social need in Canada and support the health there. So I think that would be a point where specifically for medical devices or the medical field, Health Canada could potentially get involved with. Not that I have any contacts and I'm talking to them about it, but somewhere that like if they're interested in going down that road.
A bigger role.
Yeah. But they have to be careful.
Yes.
Because Health Canada can license the device, but the procurement is the responsibility of the respective jurisdiction. So that's when things get a little bit more complex.
Yes.
All right, well, maybe we'll open up to questions from you all. I know there are some folks here that are quite familiar with medical device repair in the United States context, and maybe some of those questions would be interesting here as well. But we'll start with Alyssa.
Yeah, so doesn't have anything to do with the U.S. context.
That's okay.
Thank you so much for your presentation and really interesting topic. I actually have 2 questions. The first question is about procurement, and it seems like it would be in the public's interest for these agreements to be made public, and I'm just wondering if that is something that any of you have considered, or
You mean the terms and conditions?
yeah.
Yeah, so CMDS is working towards, you know, the website, again, it's off the corner of everybody's desks, towards creating a place where all these would be just, here's our template that we use,
Yeah.
you know? And in fact, if you think something's wrong with it, I want to know about that, if there's a way we could improve it or enhance it. We actually talked about that, can I see yours, and I can show you mine, and we can improve on some of the clauses.
One of the things that COVID did for us was it got us more in touch with the Public Health Agency of Canada, and subsequently, I don't know how recently we've done it, but we've piggybacked off their contracts, and they piggybacked off of one of ours. So you know, that collaboration goes a long way, and then if the provincial health authorities coordinated equipment procurement, I mean, we'd probably be a lot better off. I understand each province is required to be in charge of their own, but we have more buying power as a group.
One of the, I guess there's an organization out there, with a, like another name now, where they kind of set up competitive bids for products. What? Yeah, group purchase orders, and a lot of health organizations are a part of that, and so they're including some language within their, I mean, it's not necessarily public available, but to your point of like coordinating, it is kind of already coordinating, so that we could just go, oh, well, here's the 4 vendors that have met these requirements, I want vendor A, and purchase off that.
One of your engineers here in Nova Scotia was instrumental in working with them to implement language. It's not mandatory, like in the territories, it's mandatory, unless there's no clinical acceptable alternative, but they still made it a weighted function. And then the way their system works is when you're looking through the different options that are available under the group purchasing contracts that they have for equipment, you can actually change the weight on that yourself, and it'll prioritize it for you. So they've done that for us.
Yeah, I mean, it strikes me that it might even have value, like, in other sort of public sector contexts as well, like in university procurement, for example. I don't think that's something that we actually pay enough attention to, is thinking about how we could maybe, leverage collective interests for better terms.
I mean, to Kevin's point, when we're dealing with the purchasers, at least with us, they're part of a different part of the provincial government. So if we start putting policies in place here, they might also be starting to kind of talk about it with all of the other purchases that they do that aren't health.
Yeah.
So you know, it's one of the when the dominoes start falling, and you start getting that information to them, then they maybe start being empowered just kind of naturally to look at it elsewhere as well.
Can I ask my other question too, or should we?
Yeah.
Okay, I don't want to dominate the Q&A, but I have another question. So I think I mentioned yesterday I have a research project that deals with medical device repair, but it's situated in the Gaza Strip, which is obviously like a very different context, where there's, like extreme ongoing crises or extremely low resource area. One of the things that comes up a lot in that work is the role of interoperability with respect to like ancillary peripheral consumables that are oftentimes, needed for these more elaborate devices to run, but are not really available. I'm just wondering do you have thoughts about interoperability in the Canadian context or the armed force context with regard to these sort of essential peripheral or consumable materials?
I'll start with that one from the CAF perspective. So one of the main intentions with the cap is to ensure that everything's the same across the board. And when possible, when we're dealing with anything to do with NATO, we have certain standards that we're supposed to adhere to, so that way the intention there is interoperability with other nations. So we may have 3 clinics in a European country at the moment, and 2 of them are run by Canadians and 1 run by another country. It's to ensure that interoperability is there. The Gaza Strip situation specifically is very unique in that logistics are probably beyond nightmarish.
In the Northwest Territories case, which has elements, because it's a harsh environment, isolated locations, bad power, extreme temperature, so it has elements of the challenges that might be faced. We work very closely with Nunavut and communicate our procurement. We don't always match, but we line up a lot more closely than we used to, because we have regular monthly meetings with our colleagues over there. And in the case of Northwest Territories, feeds down to Alberta for higher level care. We, for example, our dialysis machines, we match with Alberta because our renal care comes from Alberta. So those communications definitely are occurring. Are they concurring as well as they could be between jurisdictions? Probably not, but they are starting to happen.
I will say that the interoperability between accessories between manufacturers is nil. I mean, on the software side and data management wise, there is standardized protocols. All of diagnostic imaging uses DICOM, so they can all talk to each other. But things that are, the IV sets from one manufacturer is not the same as the IV sets for another, and there's no impetus for them to do that because one, that constrains them to the technology, like they couldn't kind of necessarily differentiate, but the contract to supply that ongoing thing is a big money source for them. So like that's part of the sale. I do know that we, in some contracts, have specifically set up so that there's multiple suppliers. They are obviously the same thing, but there's multiple suppliers of reagents or something like that to make sure that if one company has a problem of the supply chain, there's a secondary source. We've also looked at not necessarily unifying all of our specific types of a device, so that if one device experiences a problem, then while we won't have the full fleet to cover everything, there's something, like if something is taken off the board because of a patient safety recall, well, there's something else that we can do. So we'll often maintain the inefficiency in multiple things to keep that going forward. So it is unfortunate that you can't switch sets between things, but I don't think there's a way to really standardize that without kind of impeding on competitiveness.
I don't know who made Apple switch to the Type-C plug, but that's you basically. Yeah, that's what we need to add.
Eric?
You brought up patient wait times, volume of patients, and you can't tell if that problem's created from equipment, might be contributed to by going downtime. I imagine that a lot of the equipment vendors have operating equipment effectiveness metrics on their machines. Is there a way to aggregate that or monitor it automatically so it reduces more burden of monitoring, so that you can kind of almost point the finger a little bit to say, hey, your machine causing this issue?
Well, I mean, if we have a service contract with a particular company, there's often a KPI of uptime or whatever, and we need to make sure we maintain that and say okay, if it's 99% uptime, did you meet that goal? You can also write those sort of things into contracts to be okay, great, the equipment, the spare parts need to be supplied within this period. I've seen, part of the scoring criteria is where is your part source? Is it in Halifax? Is it in Quebec? Is it in the States? And so you can kind of from that judge people on how fast they're going to be able to provide that. Post-market, I don't know if you necessarily want to rely on a manufacturer, not that they're going to be incorrect, but they're going to show themselves in the most rosy light as opposed to what you're really actually experiencing. So you want to keep your own records to be completely honest there.
But from a technology perspective, there are a few technologies that are there not many, but a few, and it's driven primarily from the US. So endoscopy, for example, is going very much fee for use. So the big endoscopy companies will go open an endoscopy clinic or lease the equipment to them, and then you pay fee for use every time you use it. So the device has a mechanism to record it. But it's strictly driven by, that kind of data is strictly driven by the motivation for profit and business case. There is inside machines at a service level, oftentimes it records usage and stuff, but it is extremely hard data to mine and
It is
filter.
hard.
Yeah, you mine it and filter it for particular incidents, but it would, to analyze it as it currently is, I would say would be a substantial
And
task.
there's some vendors that the data's there and they will not give it to you. So post-incident, you have to like, it's a loop and jumps that you have to get through to try to get that data. It's encrypted and you send it back to them and they'll read it and it's like, can I have it? And they're like, no.
But you're still kind of running on a clipboard a little bit, recording uptime, downtime, that sort of stuff.
Well, we
I
have
mean,
the CMMSs that will record.
It's a digital
content.
clipboard.
And so it's a digital clipboard, so it is a little bit better. The Canadian Medical Equipment Protection Plan, you can join. It's like a group purchasing organization, but for contracts. So like a good chunk of Manitoba, Ontario, BC use them, and they just kind of bundle all the money together and self-insure. They are starting to offer the service of monitoring metrics. Exactly when did you call? Exactly when did they respond? Exactly when did they fix it? And did they meet the required KPIs? Again, it's resourcing, right? That's an analyst position. Well, I have 8 tasks. Like, do I dedicate one just for that, or do I dedicate it? Yeah.
I've always met something. Thinking about medical devices, I hadn't realized that none of them were running on things like Windows and iOS. And thinking about a conversation we were having yesterday actually about Windows 10 to Windows 11 migrations. And I'm wondering, in terms of responsibility for uptime and maintenance of these devices, how much of that falls to the manufacturer, how much to folks like Apple and Microsoft when they're pushing these huge operating system updates, and how much lands on you guys as sort of the end contractors for these devices to deal with major OS upgrades and changes like this?
I don't think I'll jump on that one first. So our responsibility is to apply the patches and fixes that are provided to us. If we choose not to, that's our problem, and we should be doing it in timely fashion. If you as a vendor have built it off of another party, that is your responsibility to manage just as you would manage any other vendor who are supplying you screws. If they start supplying you 4 screws or they change the size unbeknownst to you, that's your responsibility to manage. The switch from Windows 10 to 11, I had some vendors go, yeah, here's the flow path. I had other people saying, oh no, we're continuing to support this on Windows 10, and here's the extended service support from Windows 10. So there's a mixture of depending on how they want to manage it, but really it's just kind of us pushing to make sure that they are managing it. Is what we're required, and if we need to, we can do other things surrounding the device to secure it, from the networking side to protect it while it remains in a normal state.
This isn't something Microsoft and Apple ever really think about at the top end of this, or?
No, they definitely don't, and I think that Windows 10 kind of opened some companies' eyes and things to that, because it was a big shift, and it's like, okay, well, yes, we understand you're sunsetting, and they've sunsetted things in the past, Windows 7, those sort of things, but this was such a dramatic kind of change. But it's some companies used it as a methodology to try to sell us new devices, and yeah, that'll never change.
There's a critical nature, and we're still just trying to work on our clauses on this in the procurement stage. You've chosen to use Microsoft as your OS. That's your business choice. You could use Unix, you could use something else that's more stable, but you've chosen Microsoft to save money, to reduce your costs. Well, we need to know for the life of the device that it's supported, because we have been where they've come and said, okay, we got to go to this next Windows platform, and you need to upgrade. We're like, cool, no problem. And they go, yeah, but the new software has additional features, and so you got to pay a completely new licensing fee, which is like 80% of the cost, right?
if you want it. And it's like, so we're trying to build the language in. You can do that, but then we own it for this lifespan. This is a reasonable lifespan. We own it for this lifespan. So if you do that, we get it for free. And it doesn't cost them anything, right? It doesn't cost them anything to do it. But they're doing their business models that way. More power to them, but we have to make sure that our procurement deals with it.
Other questions? Nathan and then Dan.
Yeah, I had a question. So sitting here, I hear we have a similar process in the States where if there's an update, some kind of patch, that has to go through the full FDA process for ensuring that, you know, like the way they ensure like a new medical device is safe to use. Any kind of software change, so it's a similar process. And that has created huge cybersecurity problems for hospitals because the OEMs are really far behind, you know, kind of catching up to the critical security updates that are being pushed out. Like Microsoft might catch a critical vulnerability and patch it 24 hours later, everyone's got the patch. And then not only the manufacturers have to propose this thing to the FDA, then the FDA has this process of making sure it's safe. And I'm just wondering, what do you think the solution to that is? Because it just seems like the regulatory state's version of safe medical device manufacturing is completely divorced from this reality of these active threat model, like constant patching that has kind of evolved in our internet-connected age. And I'm just curious about your response on that.
So, yes, I remember, I want to say like 8 or so years ago, there was an issue in the States, especially, where the FDA was requiring all of this to go back through them, specifically around devices on the iOS or Android, because these devices were using it, and you know how often you get an update on your phone, and so they were just not, like, every single thing had to go through, so you were running phones that were 2 or 3 generations behind. I believe the FDA at that point kind of redid their rulings around that, so that specifically around handheld devices, they were kind of just cleared to update and refresh as required, and so that the end user could update. But that's kind of, I was talking to Kevin the other day about it, but the SAMD is one thing I was talking about, where the operating system is divorced from the medical device software, and at least in Canada, I think there needs to be a new kind of middle ground where that can happen. But it is important that we push the medical device manufacturers to build in a cyber secure fashion around these things and recognize that that's what has to be done. I will say that repair doesn't have to go through like Health Canada if you're repairing something, which I could potentially argue that a patch is repairing something of the operating system. So an upgrade, like a service pack that adds new features to Windows, yes, that would have to go through and get reviewed. As well, for different classes of medical devices, there are different abilities for manufacturers to do things. They could make a change, I think class 1 and 2, so you can make a change, and then annually you just have to report, here are all the changes I made this past year. And it kind of, but whereas class 3, class 4, when you're starting to get into implanted pacemakers and things like that, yes, there's a bit more rigor around these sort of things, and before you can make those updates, you have to get it revalidated. But I think that there's methodologies that the manufacturers need to get in place, and they are getting pushed, kicking and screaming sometimes, but also they came from this field where nothing was connected, and a lot of the technology may still be based on that point. And medical devices are long-lived. If you think of what the cybersecurity stance was 10 years ago, that's what some of the things are still built on. And previous to that, because it took a few years for them to get built and put in place. So you're talking essentially 15-year-old devices that are now in place today. So I presented a lot of this sort of stuff to a cybersecurity conference last month here in town about like the difference in regulatory things, and we need to work together on the IT side. We need to work together to be able to protect them without them being secure themselves. But manufacturers need to step up and play and build tools provide services, recognize that patches need to be done. Well, okay, how are you going to do this? How are you going to keep that flowing out? And it's there in the legislation and the regulations. It just needs to be kind of worked on and more socialized, I think.
Daniel, yeah.
So, I don't think anyone would argue that large medical devices require trained people and clear repair manuals, like MRIs or giant magnets, where you are going to need that training and specialization. But on the consumer side, with like wearable devices now, like in Canada, very much a lot of these for biomonitoring for health issues, they're single-use disposable. And some of them last a couple of days, some of them last 2 weeks. But we're seeing in other countries developing ones where they're rechargeable and reusable, and it's more just a single component is interchangeable because, well, they only last so long and for functionality. But it kind of brings up the argument of repairability and also connectivity, that some of these devices do the same thing, but they don't talk to each other, so you can't, with a glucose monitor, it's on the user to input the information of a recalibration from a blood stick, yet you can't just have that stuff integrate itself in. So I'm wondering if it's more giving an ability to open source and connect these things so that the connectivity helps the longevity of the product throughout, because if you can't recalibrate them, they're useless. They get tossed early and you have to replace it. Kind of through software repairing issues.
So we have a brief answer to this?
Very quickly, yeah, so consumer grade medical equipment technically is a Health Canada licensed device. But it gets more complicated there. So I think of our friend from Canadian Tire yesterday. So they have repairable DeWalt or Maximum tools, and then they have their, you're going to lucky to get one use out of this, but you're only paying $20. So, those are business decisions. And from a health system perspective, it doesn't really impact us. So we do tend to steer clear of it. But I think there's business models for companies that could make their devices more repairable. It's just, it's just, unfortunately, it comes down to what people think are profitable.
I'll be really quick. We have an innovation group within Nova Scotia Health that are looking at things that we can improve healthcare, get it out of the hospital, do things like that. And so they're constant looking at these consumer devices and they're bringing them to me, and I kind of scoff at them a little bit sometimes. But as a single consumer, you don't have the wealth of us backing you up, reporting things to Health Canada, having that service and technology. Information behind us to make sure that the devices are functioning well and repaired and still operating. So it is a very kind of unique thing where it's a contract between the end user and the device manufacturer, and if they don't feel that you're qualified, back to your point, kind of having qualified repair on it, it would get kind of sticky. That not being said that they couldn't that design something and there couldn't be third-party repair to it. It's just, it gets a little bit more, and that, as Kevin said, is a business decision on their part. But after them, we are pushing them to try to make sure that, because we're purchasing them as a health organization, we're making sure that they're kind of living up to our snuff when we get into that respect.
Well, thank you, everyone. I guess we're at time, and so thank you so much, Kevin, Mike, and Alan, for your perspective on this. We'll break for lunch now, which is next door. It's just arrived, and yeah.